Hello, I'm Ruby Weber, ARIS Radiology's certified coder. The implementation deadline for ICD-10 will soon be here. We want to provide our radiologists with some documentation guidelines to ease the transition to ICD-10 and to bypass any reimbursement roadblocks the new reporting requirements may put in our way. The implementation deadline is October 1st, 2015, and all HIPAA-covered entities are required to participate. The International Classification of Diseases 10th revision was developed by the World Health Organization to collect statistical data on causes of morbidity and mortality in the human population, and is the global standard for reimbursement of medical procedures and services. ICD is used in over 100 countries to report mortality data, a primary indicator of health status, and has been translated into 43 languages. ICD-10 was endorsed by the 43rd World Health Assembly in 1990 and was first adopted for clinical use in 1994. Countries already using ICD-10 for reimbursement include Australia, Canada, China, the Czech Republic, Dubai, France, Germany, Korea, the Netherlands, South Africa, Sweden, Thailand, and the United Kingdom. ICD's 11th revision is currently in development for release in 2017. ICD is the global health information standard for mortality and morbidity statistics. It's used in clinical care and research to define diseases and study disease patterns to manage health care, monitor outcomes, and allocate resources. In fact, about 70% of the world's health expenditures are allocated using ICD. ICD-10 is the global code set, whereas ICD-10-CM for clinical modification refers to the code set developed for use in the United States by the National Center for Health Statistics. It goes beyond the statistical groupings and trend analysis of ICD-10 to more precisely describe the clinical picture of the patient. Whenever I give examples of ICD codes, although it may not be specified, I'm referring to the clinical modification. The Department of Health and Human Services is responsible for regulating the use of ICD in the U.S. On January 15, 2009, the DHHS issued the final rule to adopt ICD-10 on October 1, 2013. On April 9, 2012, they proposed a rule to push implementation back to October 1, 2014. And early in 2014, they postponed implementation one last time to 2015. An executive rule for no more delays brings us to our implementation on October 1st. Why adopt ICD-10? Because it provides a common language for comparing and sharing health information and is the foundation for identification of global health trends and statistics. Reporting with greater specificity decreases the need for supporting documentation and results in more efficient claims processing. The purpose of this presentation is not to make coders out of radiologists, but to illustrate the scope of the change and implications for the future. ICD-9's 13,000 codes is expanded to 68,000 in ICD-10. All numeric codes of 3 to 5 characters converted to an alphanumeric code structure, which, now up to 7 characters in length, allows for greater specificity and future expansion of the code set. The biggest impact of the change incorporated into the new code set is the level of detail required to code to the highest degree of specificity. Laterality has always been reported in conjunction with procedure codes, but is now incorporated into diagnosis reporting as well. The number of combination codes has been greatly increased to more fully describe complex syndromes with fewer codes, as we'll see with hypertension and diabetes mellitus. ICD-10 introduces 6th and 7th characters to designate things such as laterality, the stage of glaucoma, and the episode of care. It also introduces placeholders to keep the 7th character in position for codes with less than 6 characters. In this example, S00.01XA, the code is 5 characters in length. The X is the 6th character placeholder because A, initial encounter, has to be in the 7th position. The codes in ICD-10 are divided into 21 chapters, which I'll cover briefly. Chapter 1 is infectious and parasitic diseases. Chapter 2, neoplasms, are coded by site, morphology, and behavior, and whether it is a current malignancy or a history of malignancy that no longer exists. Chapter 3, diseases of the blood and blood-forming organs and certain immune disorders. Chapter 4, endocrine, nutritional, and metabolic diseases. The controlled or uncontrolled status of diabetes mellitus coded in ICD-9 is no longer used in ICD-10. But the expanded combination codes for type of DM, affected body systems, and complications are both more complete and more descriptive of the patient's condition, as we'll see on the next slide. Although coding for diabetes is not a big concern for radiology, this example from Chapter 4 illustrates how the combination codes introduced in ICD-10 more fully describe a patient's condition with fewer codes. For a patient with type 1 diabetes mellitus with macular edema and moderate non-proliferative retinopathy, ICD-9 requires 3 codes, but ICD-10 describes the condition in a single code, E10.331. Chapter 5, Mental, Behavioral, and Neurodevelopmental Disorders. Chapter 6, the Nervous System. The codes in this chapter specify whether the affected side is the patient's dominant or non-dominant side. G8191 is the code for unspecified hemiplegia affecting the dominant right side, whereas in G81.93, the affected right side is non-dominant in the patient. Chapters 7 and 8 are new in ICD-10. ICD-9 Chapter 6 is Diseases of the Nervous System and Sense Organs. Chapter 7, Eye and Adnexa. Sight and laterality are coded, as in this example, for elephantitis of the left lower eyelid. The stage of glaucoma is represented in the 6th character, 0 meaning unspecified stage in this example. Chapter 8, Ear and mastoid process, also specifies sight and laterality, as in the example, chronic allergic otitis media of the left ear. Chapter 9, the circulatory system. The definition of acute myocardial infarction is changed from 8 to 4 weeks in ICD-10. And as we saw with diabetes, coding for hypertension has been simplified in ICD-10 with combination codes that incorporate manifestations. In ICD-9, the manifestations are coded individually. Chapter 10, the respiratory system. Asthma codes describe severity and related conditions. Chapter 11, the digestive system. The combination codes for Crohn's disease are greatly expanded in ICD-10 and incorporate the site plus any complications or manifestations, such as Crohn's of the small intestine with fistula. Chapter 12, Skin and Subcutaneous Tissue. Again, codes include site and laterality, as in cutaneous abscess of the right axilla. Chapter 13, Diseases of the Musculoskeletal System and Connective Tissue. Not surprisingly, site and laterality are specified in the codes. Chapter 14, the Genitourinary System. Chapter 15, Pregnancy, Childbirth, and the Puerperium. Codes include the trimester of pregnancy, with an additional code from Chapter 21 to document the weeks of gestation. As in this example, Z3A.12 is 12 weeks. Chapter 16, Newborn Perinatal Guidelines. Chapter 17, Congenital Malformations, Deformations, and Chromosomal Abnormalities. While diagnosis codes for radiology services may be found in any chapter, many are found in Chapters 18 and 19. 18 is Symptoms, Signs, and Abnormal Clinical or Laboratory Findings Not Elsewhere Classified. This is where we find codes for nausea, vomiting, localized swelling, unspecified mass or lump of skin, and subcutaneous tissue. Chapter 19 is Injury, Poisoning, and Certain Other Consequences of External Causes. Codes incorporate information such as the type of injury, such as contusion, foreign body, or wound, and again, the anatomic location, including laterality. There's a 7th character to describe the encounter of the injury, whether it's the initial or subsequent encounter, and whether it's a sequela of an injury. Fracture specifics, such as whether it's open or closed, routine versus delayed healing, and if healing is delayed, whether it's due to a non-union or malunion fracture. And for intracranial injury, with and or without loss of consciousness is considered. Chapter 20, External Causes of Morbidity. External causes are supplemental codes in ICD-9. You may have heard coders talk about E-codes. They're used to document intent, the place of occurrence, the activity, and new in ICD-10 is the work status, which if it's known whether it was a civilian activity done for income or pay, or was the result of military or volunteer activity. We can code as many from this chapter as needed to fully describe a patient's condition, and codes are still not mandatory for many payers. Despite the elevation to chapter classification in ICD-10, external causes still can't be a principal diagnosis, which is why motor vehicle accident is not an adequate history when no other signs, symptoms, or conditions are documented. Another way to think of this is that we don't code an event. We code a patient's conditions or symptoms resulting from the event, which is the medical necessity required to bill for any procedure. Although external cause codes are not necessarily needed to support medical necessity on a claim, they provide relevant information for the patient's medical record, and it is still the responsibility of the imaging facility to collect this information should it become a reporting requirement for any particular state or payer in the future. And finally, Chapter 21, Factors Influencing Health Status and Contact with Health Services. This is another new chapter classification. These were the supplemental V codes in ICD-9. Now, beginning with the letter Z, this chapter contains our routine and screening exams, asymptomatic HIV status, and personal and family history of illness. These codes can be listed as a principal diagnosis. One of the primary ways you, the radiologist, can ensure appropriate diagnosis coding for ICD-9 as well as for ICD-10 is by making sure the report includes relevant clinical indications. Indications must correspond to appropriate anatomical areas and procedures, such as a contusion of the right forearm is not a relevant indication for an X-ray of the shoulder, and only confirmed diagnoses are coded. If the order states rule out, appropriate signs and symptoms must be documented. Section 4 of the official guidelines for coding and reporting for ICD-9 as well as 10 instructs coders, do not code diagnoses documented as probable, suspected, questionable, rule out, or working diagnosis, or other similar terms indicating uncertainty. ERIS's PACS auto-populates the report with whatever the client populates in the history field. Frequently, the client provides a rule-out condition or non-clinical data in the history field and then types more relevant indications into the clinical notes or comments fields. Other times, the appropriate information is only included on the worksheet that has been scanned in with the images. While we are actively working to educate our clients about what to include in the history field, the radiologist can and should take an active role in including relevant clinical information in the history field when it can be found elsewhere. Providing our billing company with a complete report greatly enhances our ability to submit accurate, payable claims. Here's an example report and how it will be coded. The exam is ankle complete right. The history, fall, rule out fracture. The technique, AP, oblique, and lateral radiographs of the right ankle. And the radiologist's impression, radiographic features consistent with an avulsion fracture of a lateral process of the right talus. The history of fall, rule out fracture. Fall fails to describe the patient's condition, and fracture can only be coded if it's not ruled out. Radiologist's impression, features consistent with an avulsion fracture. Expressions such as consistent with indicate uncertainty and consequently cannot be coded for billing. With no other clinical indications provided, the coder has no choice but to assign the more or less generic code for observation following other accident. While it's good such codes exist so we can still bill for your work, their vagueness in the face of the greater specificity built into the ICD-10 code structure sends up a red flag to payers. As the majority of cases are negative for the suspected conditions for which they were ordered, it becomes easier to understand why obtaining the patient's signs and symptoms is so crucial to successful coding. In this example, suppose the indications of pain and swelling were typed into the clinical notes field. You should copy and paste them into the history field along with the fall rule-out fracture that was originally entered. They will be populated into the report and the billing company will be able to code them. The examples I gave of M25.571 and M25.471, in which the fourth character, 5, indicates pain, 4 indicates effusion, and in both cases, fifth character, 7, indicates the ankle, and the final character, 1, indicates the right side. And again, in the absence of a confirmed diagnosis, only the patient's presenting signs and symptoms can be coded to support medical necessity for the procedure. The Balanced Budget Act of 1997 requires the referring physician to provide diagnostic information to the testing entity at the time the test is ordered. Any exam submitted to ARIS for interpretation that does not provide relevant clinical indications can be rejected by the radiologist to have the facility contacted for the required information. So the burden is on the referring facility to provide adequate clinical indications, but the implications for patient care are evident when we think about rejecting studies for clinical history. Bear in mind that the most common reason reports are referred back by the billing company are for inadequate history. The good news is ARIS's top 10 ICD-9 codes by volume all have a direct counterpart in ICD-10, and our billing company doesn't foresee any major reimbursement issues for ARIS when they convert to ICD-10. This slide shows our top 10 most coded primary diagnoses. Please note that number 5, observation following other accident, or encounter for examination and observation following other accident, is the code used when no relevant clinical indications are provided other than trauma or injury. As we have seen the level of specificity included in most ICD-10 codes, these all seem very nonspecific, even vague. This may become a red flag to payers and auditors as ICD-10 takes hold. The slightly less good news, then, is that while there are still codes to accommodate vague clinical histories such as trauma, injury, or pain, the risk for claims denial will increase as payers are expected to narrow their definitions of medical necessity due to the greater specificity afforded by ICD-10. In conclusion, ICD-10 becomes effective October 1st, 2015. You should begin incorporating the additional documentation into your reports now. It's helpful for ICD-9 coding currently, but also positions ARIS for success with ICD-10 by maximizing reimbursement and minimizing denied claims. ARIS's contracted billing company, Streamline MD, produces and distributes a monthly newsletter devoted to radiology-specific issues. Past newsletters, including much of the information presented here, are available at www.streamlinemd.com/radiologyviews.aspx. I hope this answers some questions you've had about ICD-10 and its impact on your workflow. As you see, we will continue to do business after October 1st. We're working with our clients to improve the quality of the supporting information they provide to you and to the people who make sure you're paid for your work. Thank you for your attention.